Chief with Becker's Healthcare. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have, and will follow up on questions they do not have the opportunity to address. You'll receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Dr. Jeff Davis is the Senior Medical Director of XG Health Solutions. Before joining XG Health, Dr. Davis was the CMO of Aviva Health from Kaiser Permanente, a care management and analytics and population health improvement company that is a wholly owned subsidiary of Kaiser Permanente. Dr. Davis received his medical degree from the Columbia College of Physicians and Surgeons in New York and completed both his pediatric residency and his clinical research fellowship training in medical genetics at the University of California, San Francisco Medical Center. Alex Zimmerman is a senior consultant for XG Health Solutions. In his role, he assists organizations in the development and implementation of reliable care delivery pathways by using the ProvenCare methodology. Prior to joining XG, Mr. Zimmerman worked as a critical care RN for Geisinger Medical Center in Danville, Pennsylvania. Mr. Zimmerman holds a BSN from Indiana University of Pennsylvania, as well as his MSN in Administration and Organizational Leadership from Mansfield University of Pennsylvania. Dr. John Bulger has been Chief Quality Officer for the Geisinger Health System since 2011. He founded Geisinger Medical Center's hospitals model in 1999 and led the program's development to include 6 hospitals and more than 100 physicians and advanced practitioners. He holds appointments as a Clinical Associate Professor of Medicine and Regional Assistant Dean at Philadelphia College of Osteopathic Medicine and an Associate Professor of Medicine at Temple University School of Medicine. Dr. Bulger is a lifelong resident of Pennsylvania. He is a graduate of Juniata College, PCOM, and the Pennsylvania State University. And Dr. Alfred Casal is Chairman of Surgery for the Geisinger Heart Institute, Co-Director of its Cardiovascular Service Line, and Associate Chief Medical Officer for Geisinger Northeast. Dr. Casal is active in local, regional, and national surgical societies within which he has held leadership roles, and he speaks often as on clinical and policy topics. He joined Geisinger from Atlantic Health System in New Jersey. Dr. Casal graduated from the Johns Hopkins University with a BA in Human Biology and then earned his medical degree from the Johns Hopkins University School of Medicine. It is now my pleasure to turn the floor over to Dr. John Bulger to begin today's presentation.
Thank you, Molly, and thank you for those of you on the phone being with us today. We're excited to share with you our experience we've had over the years with ProvenCare. You have on the agenda in front of you, next slide. First, we're going to talk about, and I will talk about, the purpose and goals of ProvenCare. Then Dr. Casal will come in and go over the key components and successes of ProvenCare Acute. Then Jeff will discuss the key components and successes of ProvenCare Chronic, and finally Alex will finish up talking about how one can get started and where to focus for early successes. Next slide. So as I said, I'm going to go really through the purpose and goals of ProvenCare, focused on outcomes, specifically readmissions and standardization, and really talk about why we started this, where we were, and where we've gotten to. Next slide. So why was ProvenCare created? And you could you look back to 2005, 2004, when we first started having the discussions around why to come up with an innovative program such as ProvenCare. And really these bullets you see in this slide exist today as well, maybe to a somewhat lesser degree, but I think all of us who are involved in healthcare aren't necessarily happy with where we are and are trying to find ways to improve the care we deliver to our patients. So The appropriateness of care is really uncertain. There's been a lot written about overuse of treatment and whether certain treatments are actually needed or not needed. The seminal paper that was published by Beck McGlynn in New England Journal talked about unreliable compliance with care. That was back in 2003, but again, a lot of that still exists today, and the notion that somewhere around half of the evidence-based guidelines that all of us in healthcare have agreed we should adhere to don't get adhered to. There's huge geographic disparities. The data from the Dartmouth Atlas is really easy to get to and look at and understand and see what those disparities are. And outcomes vary widely too, and the outcomes really don't mesh with what we're paying for it. So there's that lack of accountability and inverse relationship between quality and cost. Patients many times aren't engaged in their care, and it's almost like the providers and patients are siloed and really are working together with to get the best outcomes possible. Payment is a la carte. That's become very clear with the increased transparency of charges in healthcare, and sometimes the increased transparency of actual costs and what patients pay. The recent article probably some of you saw about the cost of MRIs in California and tenfold, almost 20-fold differences between one center and another that are very close. And lastly, there are perverse incentives with our payment model, so that hospitals, healthcare systems actually get paid more for outcomes that aren't desirable. So having certain types of complications actually increase the payment you get in healthcare and aren't something that is very easily explainable, certainly to patients, and not something that any of us, I believe, have in our aspirational goals. Next slide. So, we sat down and said, well, how do we fix this? How do we get at changing this paradigm that exists? And that really got us to the basis of what is ProvenCare. So ProvenCare, the goal really is to facilitate delivery of high reliable evidence-based care, to get it right every patient, every time we do it. And to provide that evidence so we aren't at that juncture where we say, well, only half of the things that should get done with patients get done every time. We look at using evidence-based practice and really getting down to brass tacks to what are those best practice elements that we need to implement to reduce unwarranted variation in the delivery process, and understanding that there is going to be some variation in the process, but there's a difference between unwarranted variation and variation that's warranted. The difference between using maybe a particular type of drug or particular brand of drug to treat something and then not using that drug at all might be one example of the difference between warranted and unwarranted variation. ProvenCare really focuses on using a multidisciplinary and interdisciplinary use of the clinical team. So we try to sit down and identify through consensus, so it's a bottom-up process of the people who are actually taking care of the patients, the doctors, the nurses, the pharmacists, the physical therapists, agreeing on what the evidence is and what are the best practice elements that need to be done on each patient, and then basing those best practice elements and then figuring out how to integrate them into the practice. So again, they happen on every patient every time, which means you need to change what you do in your practice so that the best thing, the right thing, is the path of least resistance. And then finally, we do a lot within the Geisinger Health System around optimizing and using information technology, many times specifically the electronic health record, to impact those workflows, again, to make the right thing, the easy thing for the provider to do to ensure reliable delivery of the best practice elements. Next slide. Part of ProvenCare also is really a cultural change, a socialization, if you will, around the providers and the care team understanding, becoming aware of the care they're providing, and then working together to be able to change that care. And that includes adopting what the best practice elements happen to be, taking a step back and looking at the current state they're in, and then figuring out how to implement changes to change that current state. And then over time, you really end up institutionalizing those changes to where, when you have done it for a while and you sit back and look at where you were and where you are now, it's I think many times difficult for you to understand how you did it that way in the past, knowing that you changed things so dramatically. And it's no really different when you're trying to diffuse innovations. The bottom part of this slide is something many people have seen. Is there are always going to be champions and people within either hospitals or service lines within organizations who are innovators and early adopters and want to go out and move things. But it's getting to that early majority and then really getting past the tipping point so that you have the late majority that is going to change and make be the glue that makes the institutionalization stick. Part of that starts with the awareness. So those innovators and early adopters of the change really need to work to help make everybody aware of the potential benefits of doing a program like ProvenCare, and again, really changing the culture. And what we've seen is, we talk a lot about the outcomes we've seen, and they're very positive, but many times you can't completely, from a causation standpoint, tie the outcomes back to specific best practice elements. Or, for example, you see that you've done the best practice elements and increased the utilization of those, or the adherence to those by 20% doesn't necessarily mean that your outcomes increase by 20%. Many times the outcomes increase much greater because you've changed the culture within that work unit, within that service line, and they change the way they think about things and the way they take care of patients. Next slide. We like to focus on these 5 areas when we're trying to redesign the workflow around a given disease entity, whether that is heart failure or whether that is surgery for coronary artery bypass or whether that is the outpatient treatment of diabetes. And these kind of these areas are real areas of focus for us and real tenets that we try to go through each time we're doing these things. First is trying to eliminate things that don't add value. If you can't tie it back to something that's going to help a patient, there's no reason to do it. And I think all of us know when you actually sit down and go through the workflows that you do in the course of a day to do things, there are many, many things when you take a good look at it that you can eliminate. The second is anything that can be done automatically should be done automatically. So if I can automatically send off an order to make sure that everybody over 65 gets a pneumonia shot, I want to do that. I don't want to have a doctor or a nurse or anybody have to check the box to get that done. Simply the fact that the patient sits in the right bucket should get that done. Third is to delegate things, and we do a lot of work within the Geisinger Health System, and we use kind of the mantra of using people at the top of their license. So if an office assistant can do it, an office assistant can do it. If a nurse could do it, a nurse should be able to do it. If the doctor has to do it, the doctor has to do it. But we shouldn't have physicians and nurses doing things that we can either automate or we can delegate to someone else on the team. And that works very well because it's fulfilling really across all levels of the team, because all levels of the team feel like they're part of the work, and all levels of the team also don't feel like they're doing what sometimes is called busy work that doesn't need to be done by them. Fourth, we try to incorporate new workflows where possible. So where we can change the flow, again, with an eye to making the right thing the easiest thing to do. Sometimes that's putting reminders in the electronic health record, but many times that's just completely redesigning the workflow of how you do it. So not constantly sending pop-ups to providers telling them to do one thing or another. It's actually redesigning the whole workflow so when the patient comes in the door, the right people can do the right thing. And lastly, it's finding ways to activate patients and families. So some of that is around asking patients their preferences, some of that around getting patient-reported outcomes or questionnaires so that you can, before the patients ever come into the visit, you can find out what they need. Do they need the flu shot? Do they need an pneumonia shot? Are they allergic to certain medicines? So that you don't have to go through that every time in every visit. The last thing is the more you can activate patients, the more you can get them involved in the care, the more they're likely to do the things you want them to do that will help their care. For example, if you have a best practice element around a surgical procedure that may include chlorhexidine baths prior to the procedure, the better you do at activating the patient before they ever get to the pre-op setting, the better you do with educating them, the more likely they are to fulfill that step, which we all know will be helpful in the end because it'll decrease infections. Next slide. So the last thing that I'm going to talk about is how does this tie in with bundle payments? And bundle payments has clearly been something that has been at the forefront of discussion around healthcare, and then secondarily with the advent of the Center for Medicare and Medicaid Innovations bundle payment initiative has taken on new meaning for many organizations. So the ProvenCare approach can be used to create bundle payments, and in fact when we started doing ProvenCare, that was and continues to be the last step of ProvenCare, is coming up with a bundled pricing approach with third-party payers. We did it initially with our own health plan, Geisinger Health Plan, but it can be done in other ways. When taking risk, though, you need to have more than just the data. You really need to be able to redesign the care. So just having the data and putting it out in front of people doesn't actually necessarily change the cost. You need to be able to go through the cultural redesign. You need to be able to go through the workflow redesign we just talked about and really incorporate new workflows if you're going to be successful from a bundle payment standpoint. And ProvenCare provides that framework to bundle episodes together to both redesign the care and to fundamentally change the way you think about things. And in that instance, Geisinger has and is serving as a facilitator convener for 20-plus hospitals engaged in the CMMI Bundle Payment Collaborative. And we've seen many of the same gains that we had internally as we've worked with those 20-plus hospitals and systems in changing the way they provide care for patients around this bundle payment piece. So now I'm going to turn it over to Al Casal, and he is going to discuss the key components and successes of ProvenCare Q.
Thanks, John. Good afternoon, and welcome to our webinar today. The principles that John outlined for ProvenCare basically can be summarized by saying it is Geisinger's process to eliminate unwarranted variation and provide more efficient, effective, safe, and as we've learned over the last 8 years, less expensive care for patients in a variety of acute and chronic diseases by focusing on the documentation of appropriateness, by developing evidence-based best practices, hardwiring those through the use of reliability science and industrial design principles into the day-to-day flow of patients in the system, activating patients and their families so that they become engaged partners in the process. And then that could be the end of the engagement for those companies or hospitals or systems who are focused on the process and quality improvement areas. But as John focused on in his last few comments. We've also used the ProvenCare process as the nucleus of a bundled payment scheme that aggregates into one charge the care for an episode related to an acute episodic surgical process, and included in that coverage for 90 days of related complications or readmissions. We're going to spend the next 20 or 25 minutes focusing on that process for acute episodic inpatient hospital care. After that, we'll focus on the application of the same principles of eliminating variation and reliable care delivery for chronic disease management. Next slide, please. So ProvenCare for acute episodic care is a structured approach to provide two things. First, increased quality at the same time as reduced cost of care. So you see, it can be, and it has been for us, the foundation of our system's commitment to move from volume to value in providing and being reimbursed for health care. Intrinsic in the durability of the ProvenCare model is the use of techniques of reliability science and industrial engineering to design care processes using electronic health records to build those best practices that we want to assure are delivered to every patient every time into the default practices or the default care that will occur, not depending upon hard work, diligence, caffeine, or sleep to assure that things get done, but to depend on the entirety of the system's resources. One of the earliest learnings in our evolution of the ProvenCare model was the recognition that precise and well thought through definition of the population for whom the program was being designed is critical in achieving success. As an example, when we developed our first acute episodic surgical program, we focused on coronary artery bypass grafting for a variety of reasons. But in the beginning of that process, it became clear that narrowing the group to elective coronary bypass was critical because the needs and the expectations for care rendered to patients who are acute or urgent or emergent was going to be different. So again, the first step in our development of what's now over 12 ProvenCare programs was precise definitions of the population. The use of a process design tool is one of the real advantages that Geisinger's connection with XG has now provided us. When we built the first few ProvenCare programs, we were building prototypes. We were cobbling together a structure based on learnings week by week. Having achieved a fairly successful model, we recognized that not only did we build those prototypes, but we built a factory to build other prototypes. So by refining that process over a series of iterations, we've now gotten to the point where Geisinger and XG can offer to other interested sort of organizations a very streamlined, very efficient, very well thought through model to guide their own evolution and frankly to short circuit or avoid some of the dead ends and alleys and non-productive pathways that we wandered in during our several-year journey to getting ProvenCare up and running the first time. What we've seen uniformly in the projects for acute episodic care when fully implemented has been great adherence to the guidelines when properly thought through and translated into best practice elements, along happily with improved clinical outcomes, better coordinated and organized care, with improved patient satisfaction, and frankly, better financial performance as we'll document in a few minutes, not just for the acute episode of care, but for the entire bundle of care, including 90 days of postoperative management. Switch to the next slide, please. This is the key in terms of understanding what acute proven care for episodic inpatient care is about. We outlined this briefly a few minutes ago, but let's go through these carefully one by one. The way we have delivered improved quality at lower cost and thereby increasing value has been by delivering on these 6 modules of proven care. The first is clear documentation of the appropriateness of the care. Now, back in 2004, when we were first talking about this, this wasn't so well defined in our industry. Now, appropriate use criteria are available broadly for a variety of topics. But clear documentation in the chart of the why a patient is having a procedure done is the first step. The second step in our development of proven care and in your implementation of a project like this would be gathering together the group of clinicians who are ultimately responsible for the patients in your defined population and working with them either from scratch or with the jump start that XG and Geisinger's proven care pre-work can provide to establish evidence-based best practices. Now, we often say evidence or consensus-based, but we would warn that in the first iteration, almost all places are best off focusing on the evidence-based best practices. And in the absence of solid authoritative evidence from the outside, consensus developed best practices can be useful, but takes an awfully well-functioning group of clinicians to agree on things that haven't been raised to the level of class 1 evidence and randomized controlled trials. To summarize what I mean by this is we start off new groups that have not done this kind of work before by having people agree on those things that I said you'd fail your board exam for getting wrong. They need to be topics and issues and elements that are not up for a lot of argument because they really do rise to the level of every patient, every time, should have them delivered. The third and perhaps the most critical aspect of our proven care model is the use of the 5 principles that John went through, the eliminate, delegate. The use of those principles and industrial design concepts of flow and hard wiring to build into the day-to-day management of patients the tools that will assist the clinicians in delivering on all of the elements that they've committed to by default without significant clinician input, and in fact rely on clinicians to stop or to alter those elements that are inappropriate for a specific given patient. It's the difference between starting off with a white sheet of paper and relying upon memory and hard work to enumerate the entire list of things that are right for a given patient, or using a preconceived checklist of appropriate issues for a specific patient population as the default practices that will be delivered unless an individual item is struck from that checklist. The fourth component is the notion of turning patients and families from passive entities to whom these things are done to active participants in the program and make them realize that their behavior both during and after the hospitalization has a major impact on the outcome of whatever procedures are being contemplated. The fifth component of ProvenCare, as Geisinger's deployed it, is the financial component, the notion of creating an episode of care bundled price that includes all of the care required from the moment the decision to perform a procedure or a patient is admitted for a diagnosis, through all of the in-hospital care, through discharge, through their perioperative and postoperative management. And then the sixth element is the inclusion in that bundle of the financial responsibility for all complications or readmissions at a Geisinger facility that's related to the index procedure. In a sense, what the New York Times called the warranty for initially our coronary bypass project, but now for all of our ProvenCare programs. Next slide. So I want to dilate for a few minutes about the notion of the best practice elements, because these are the building blocks for the ProvenCare commitments. When we talk about best practice elements, we are going from the notion of guidelines and generally accepted commitments that, as I said earlier, you should, quote, fail your boards for getting wrong. But translating those general guidelines into very specific, very clear definitions of behavior that are observable, standard, and can be assigned and attributed to individuals. What do I mean? Well, one of the ACC AHA guidelines that we used in our first iteration of the coronary bypass ProvenCare project was the admonition to use antibiotics appropriately so to minimize the likelihood of a perioperative wound infection. Well, that's very hard to argue with, but it's also very hard to measure. So our group of clinicians gathered together and translated that guideline into something similar to this statement. All patients undergoing an elective coronary bypass procedure at a Geisinger hospital will have a first-generation cephalosporin at a dose to be determined by a weight-based dosing algorithm administered by the pharmacy, given within 1 hour of the initial skin incision, IV, by the anesthesiology team, repeated every 4 hours until the last wound is closed, then maintained postoperatively every 6 hours for no more than 48 total hours from the initial dose. Now that's incredibly detailed and granular, but by being that specific, we can then hardwire that into the order set as well as all of the accountabilities for the nursing staff and the physician staff after the fact. So that translation process of guidelines into that type of granular commitment does two things. Not only does it allow the hardwiring, but it begins the very important process of clinician buy-in to all of the best practice elements. Without that grassroots level involvement of the clinicians working together to establish those best practices, we've found that a top-down push of these elements faces so much resistance as to make the rest of the project very difficult to implement. Next slide. Having now lined up a number of guidelines and translated them into a series of best practice elements, the next step that we guide groups through is deciding what the current flow for patients through the care process is in a given facility. This is a cartoon, which is essentially a map of both the time and the temporal and spatial sort of flow of a patient through our coronary artery bypass grafting care. We see them in clinic. We see them the morning of surgery in the preoperative area. They go to the OR for the procedure. They convalesce in hospital and then are discharged, and then we see them within a week to 10 days in the clinic afterwards. By holding up every component of every best practice element against this map, we ask ourselves, what can I do at each of these times and places for each element to improve the likelihood that it will be reliably delivered each time? So as an example, for the antibiotic statement that we were just talking about a few minutes ago, I would need to ask in the clinic if the patient is allergic to cephalosporins. I would have to make sure that the order is in place in the preoperative area. I would have to be sure that it was administered in the operating room according to the schedule. We'd have to make sure it was reordered postoperatively and maintained and then stopped at the appropriate times. So underneath each one of these columns, we're going to wind up with a series of opportunities to deliver on the best practices. The important next step in evolving a program in our circumstance is to then take each column and turn it into a tool of some sort, whether it's an order set, whether it's a checklist, whether it's a pre-templated note of some sort, whether it's a protocol or a policy that is somehow automatically implemented. Now, originally, when Geisinger started this, we did this with pencil and paper because our install of Epic in hospitals was not yet completed. So in 2005 and 6, when we started the coronary project, this was clipboards and pre-printed order sets. We then, when Epic became implemented in the hospital setting, converted all of those pencil and paper tools to electronic elements within within Epic, and in that process learned a tremendous amount of shortcuts and of ways to use standard and customized EHR tools to accomplish in a much more efficient, a much easier to track way the hard work that pencil and paper had achieved in the years before that. So with that process, with having the documented appropriateness, established best practices, translated them and hardwired them into the day-to-day care, activated patients, bundling the price for all related care into one package, and including in that package all of the responsibility for related complications and readmissions, what did we find? Next slide. So the first thing we found was that when we started back in February of 2006, just about 70% of all patients undergoing coronary artery bypass grafting at Geisinger hospitals had all 40 of our best practice elements delivered spontaneously. When we deployed the tools, originally pencil and paper, to reliably hardwire the best practices into our default care, it took us about a year to get up to 100%, meaning all patients received all elements every time. It fluctuated between 90 and 100% now for over 7.5 to 8.5 years, documenting something that we think is very important, that once this culture change occurs, once the team gets used to relying upon the certainty that the right things are going to be deployed every time, they trust the process. The fluctuations between the 90 and 100% that we've seen were usually due to staff changes and education of new physician assistants or new nurses, and again, taught us something about the process of bringing people into the team. Next slide. The use of the electronic health record as the repository of the tools and the checklists has allowed us to move from a very labor-intensive pencil and paper, individual, going to charts to abstract them process to an automated reporting system where data is captured in real time, can be reviewed and reported out in a variety of ways in real time for both internal and external use. It also allows us to very rapidly identify areas where traction is slipping or never achieved so that we can target our improvement processes at precisely the time and the place where they're going to have the most impact. Next slide. So we showed first in the graph that we had just looked at that we could do what we said we would do. That is, we could deliver on a series of 40 best practices 100% of the time. What were the epiphenomena associated with that in terms of cost and patient's outcome? Well, this slide summarizes our initial experience with the coronary artery project's clinical outcomes. From an already very high bar based on the Society of Thoracic Surgeons database and the predicted outcomes for these different surgery-related complications, we improved from that already very, very enviable sort of high bar. So the first lesson, we could do what we said we would do. Number two, patients improved. Next slide. Happily, in addition to patients doing better when we reliably delivered on this care, the contribution margin for the episode of care related to that coronary bypass increased by 19 to 20%, somewhat based on the length of stay, but also based on the improvement in complications, and especially from the decrease in the variability that made care inefficient. Next slide. When we did the analysis of the total cost of care by Geisinger's insurance component, our Geisinger Health Plan, using the same patients analyzed if the old contract of piecemeal payment was in place or the ProvenCare bundled package was in place, that we saved about 5% of the total cost of care, and that coronary bypass at Geisinger cost about a third less than any place else that GHP paid for it. This is when the hair on the back of our neck stood up, because it was the first documentation we had had that by doing the 6 components of ProvenCare, documenting appropriateness, establishing best practices, hardwiring them, activating patients, bundling a price that included a warranty for related complications and readmissions, patients got better. We profited more from a 5% smaller total spend by the insurance company. Next slide. Any questions? We're going to move on to a discussion about chronic disease management ProvenCare projects, but I'd be happy to answer any concerns or questions about the acute episodic project or the overall principles of ProvenCare.
Great. Yes, we've had a few questions rolling in, Dr. Casale, so I will get on to those. But just a reminder for the attendees who are listening in, if you want to submit any questions you have, you can type them into your control panel in the space labeled Enter Question for Staff, and then click Send. So there also, we'll take 5 minutes here, and then I know at the end of the program as well, another Q&A portion. So one question here, let's see. So bear with me here with my pronunciation. I'm going to try and get my clinical my clinical talk straight. But given the advances in interventional cardiology for revascularization strategies versus CABG, and with syntax and CTS data showing that CABG is preferable for select patients, how do you manage the volumes for best practice CABG given that the interventional cardiologist usually decides when you receive a surgical candidate, i.e. at times it can be a patient referred to you now with 4 to 6 stents?
Well, thank you. Basically, the question is not only concerned to the person who asked it, but it's a critical question for a lot of large industries and payers for healthcare. One of the, we believe, sort of side benefits to our developing ProvenCare was attracting the attention of Walmart, among other sort of large purchasers of care, who are incredibly focused and concerned not only on the cost of care for an individual patient, but almost more on the appropriateness of whether that care is required at all. They've seen and recognized, along with other big companies throughout the country, that it's almost small potatoes to argue about the cost of managing an individual patient when 30% of what they're paying for, or 30% of the patients that they're paying that price for, could have some less expensive, more effective care delivered. So to answer the question directly, in ProvenCare, because of the commitment, the #1 commitment to documenting appropriateness, we believe that before any conversation about how to perform these procedures is entertained, the decision that this is an appropriate patient to be treated has to be made. Now, specifically relating to coronary bypass, the notion of the heart team approach that the American College of Cardiology, American Heart Association has promulgated in their 2011 guidelines for coronary artery grafting, raised this to a Class 1 guideline that patients in certain categories, and certainly those with syntax scores that would suggest that coronary grafting was more appropriate, should be cared for, and the decisions made by this combination of a heart team, including surgery, cardiology, primary care anesthesia, and when appropriate, medical doctors from appropriate medical specialties. So we're with you. We think that before talking about how to do the procedure, whether this is the right patient to do it has to be built into these systems.
Oh, sorry, Dr. Casal. I was on mute there. So another question that came in is Medicare is pushing to eliminate bundled payments in CABG, total joints, and other procedures by 2017. Do you have any thoughts about this?
Yeah, this is John Bulger. I would say the CMMI bundle payment initiative is clearly a fluid process. It may be too strong to say they're pushing to eliminate, but clearly, what that program looks like today and what that program will look like several years from now, I think is up in the air. And in fact, to the standpoint that there's kind of monthly and it seems sometimes weekly and daily discussions as to how that will look, including how the risk is calculated, how the payments are going to be calculated. Either way, I think we looked at it, and I think CMS will look at it as well, as when you're talking about defining the appropriateness of care, as Dr. Casal discussed, and defining reliable care. Those entities are high-volume diagnoses that both Medicare has in their portfolio, but other third-party payers and health systems have in their portfolio. So even without the bundle payment, the process of going through and delivering reliable care for those areas, with the knowledge that when you do that, it makes it much easier to get to a higher value of care, both on the quality and cost side. I think won't change the realities of them being key diagnoses.
Okay, so that will conclude the halftime of question and answer session, and then I'll let you resume the program, and we'll take some more questions at the end.
Hi, this is Jeffrey Davis. Let me add my welcome to everyone on the phone. And so we're going to make a switch from the inpatient side of the world to the outpatient side. And so next slide. And so we're just going to start off briefly talking about definition and goals. And so let me start with the definition of our ProvenCare chronic disease and prevention management platform. So it's a systematic approach for the reliable delivery of evidence-based care in the outpatient setting. So some key themes here: systematic, so it's a structured process; reliable, every patient, every time; and evidence-based. So we use the scientific literature to direct our care. Our goals are basically twofold. First is to generate outcomes that are measurable. So we have quantifiable metrics to assess improvement. Scalable, we can apply and implement this system in many locations in a cost-effective way. And of course, reliable, right care, every patient, every time. And the second goal is to prospectively and proactively identify patients who need additional care. Next. And so I just want to, just as Al summarized the components of our ProvenCare Acute, let me do an analogous summary, if you will, of ProvenCare Chronic and prevention and its key components and strategies. So the first, and you've heard this both from John and Al, the use of clinical process redesign. And so this is focused in our chain-based model, and we use those principles of process redesign: eliminate waste, automate any manual work, delegate to non-physician levels of staffing, incorporate those processes into standard everyday and hardwired into our EHR, and activate patients and families. The second component is the use of best practice teams. Now, these are essential elements of our process. They're teams comprised of both clinical and IT folks who leverage and synergize their skill sets in order to do two things. The first is to lead performance improvement activities or initiatives or projects, either within the larger organization or department or at the practice site. And the second is to ensure that clinical decision support processes are hardwired into our EHR in order to, again, ensure reliability and consistency of care. So our third component is the identification of care gaps and, of course, the closure of those care gaps. And we use our disease-specific registries to both monitor and track those care gaps, and then to develop both patient-specific and population-based intervention. The fourth component is our employment of all or none performance measure sets. And this is really a key fundamental principle of ProvenCare, chronic and prevention. And so these all or none approach underlies the belief that in order to optimally manage individuals in terms of chronic care, we shouldn't do it piecemeal. It isn't one metric versus another, that we should be taking all the evidence-based literature and managing our patients and caring our patients with all of what's recommended, not just some. And fifthly is the alignment of provider incentives. That is, to use financial incentives to motivate our providers and our clinical teams to achieve quality outcomes. And lastly is the promotion of patient engagement. But we know that 90% of care of individuals with chronic conditions occurs outside of the physician office. And so in order to motivate and activate our patients to initiate their own self-care processes or care at home and in their communities is extremely important in order to generate quality outcomes of our population. Next, please. And so I want to take that 30,000 high-level view that I just summarized and bring it down to a more 300-foot view, if you will, down on the ground, and share with you a more concrete way in which our process design might be implemented. And I'm going to use diabetes as an example here. So as you look at this slide, going across the top row, those are our principles of process redesign. Again, automate, delegate, incorporate, and activate. And so going to the automate section, automate any manual work that we can, we clearly use our EHR to do that in an optimal, maximal way. But I also wanted to highlight two particular processes in terms of concrete examples. And one is our pre-visit planning. And that's where from our enterprise data warehouse, we identify all patients who are going to be seen or scheduled to be seen in our clinics 2 weeks ahead of time. We take those lists of patients, we distribute them to our practice sites, and then individuals or folks within our practice sites then reach out to our patients who have care gaps and have conversations and then develop plans in order to close those care gaps before they come in to see their physician. And all that with the purpose of making that physician-patient visit a more effective and valuable event. The second example is use of our reminder letters for individuals with chronic disease. We send these out on a semi-annual basis, and these letters essentially summarize important aspects of their conditions, what care gaps they might have, and their goals of treatment, and hopefully that becomes a lever to activate their desire to close those care gaps and help with their care. The second, going to the right to the second level, is around delegate to non-physician staffing levels. So I itemized 3 different staff within our clinical team: clerical, clinical nurse, case managers. Let's start with clerical. Clearly their accountability and tasks is around scheduling. I use the example here of flu vaccinations or pneumococcal and follow-up in order to achieve those things. They have clear accountabilities for these tasks. Our clinical nurses have responsibilities around making sure appropriate immunizations are completed, coordinating necessary lab testing, and in the case of diabetes, if a patient needs a foot exam or a referral for an eye appointment or urine for microalbumin, that is clearly, again, the accountability of our clinical nurses. And lastly, our case managers, particularly our case managers who are embedded within the clinic or practice sites as part of our medical home initiatives. They have clear accountabilities around care coordination and education around our most complex patients within the clinic, within the practice site, that is. So moving again to the right and incorporating our processes into standard and hardwired methods. So on the nurse level, we have what we call a rooming process, and we employ a specific embedded rooming tool, a template, which dictates or stipulates tasks that our nurses ought to be doing before that patient goes in to see the physician. And so those would include things such as talking and enrolling our patients in our patient portal, My Geisinger, assessing tobacco or smoking status. And in addition to that, embedded again in the EHR would be best practice alerts that are more task-oriented. So when a foot exam is needed or urine microalbumin, that pops up as a reminder, and that again is the accountability and responsibility of our nurses. On to the provider level, and our providers their focus is around complex medical decision making. So the kinds of evidence-based alerts and reminders they'll get are around, for example, A1C control in diabetes, blood pressure management, or LDL or cholesterol control. And lastly, into the activate level or part. So I have two examples here again to make this much more concrete. The use of our patient portal, extremely important in our patient engagement desire and strategy. So 24/7 access for patients. They can do multiple kinds of activities from scheduling to refills of their medications. But in my mind, most importantly, they can communicate with their clinical team. And they can do that again on a 24/7 basis. So it's an extremely important process of patient engagement. We know that people who are more engaged, and a proxy of that engagement is their interaction in the patient portal, the better health status that they have. The next example would be around our patient report cards. And so these are report cards that we develop for the time on which a patient visits the physician or the clinical team. And in these report cards, they have what gaps in care exist for that individual, so they're very tailored, their goals, what they can do to achieve those goals. And so that acts as a very important basis for dialogue with their clinical team at the time of the visit. Next. And so here's an example, not an example, here's our performance measure set for diabetes. I won't read these things, they're fairly self-evident. They're comprised of 9 components in our system, and of course they're derived from our review of the scientific literature and consensus around our clinical experts. And so this all or none is, in order to optimally achieve care of a patient with diabetes, we have to fulfill all of these quality metrics in order to do that. And so our measurement statistic around this all or none performance measure is the percentage of our diabetic patients, whether from a provider panel or on the whole practice site, the percentage of diabetic patients who have achieved completion of all these measures. So that's our measurement or performance statistic of which we incentivize our clinical teams to achieve. Next, please. And so this is a little bit about our journey around the implementation of our all or none process. On this slide, I only have 7 of our 9 elements, but just because of real estate on the slide. But there's a couple things I want to highlight around this slide. So we thought we were actually doing really well relative to our own performance around individual diabetic or diabetes metrics. But when we embarked on our ProvenCare approach and methodology, we established a baseline, and as you can see, our baseline, which is that first column under 2006, less than 2.5% of our total diabetic population, that amounted to around 25,000 diabetic members at that time, achieved this all or none completion. That was a big aha for the organization. We really had to take a step back in terms of how we, again, were approaching our patients. And we had done that. This was a process that was going on for 18 months before we embarked on this ProvenCare platform. So this was a big aha for the organization. As you can see, over the next year, as visibility was generated in the organization, we improved that compliance threefold, up to greater than 7% of the diabetic population. And then fast forward to 2014, at this point we're almost at 20% of our total diabetic population that completes all of the elements within the all or none performance measure. Now some of our clinics are doing 30%, some are doing 15%, so this is our overall average in our system. And the real goal here is that we see improvement in this all or none performance set every year. That's our goal, and in terms of our requiring or seeing that improvement every year. Next, please. So I put this slide in to highlight an article that we had just published, June of this year, of the American Journal of Managed Care. And this was a study that was really important to us because it is a proof of principle, both internally and externally around assessing the effectiveness of our care under a system of care. And I want to emphasize that again, under a system of care as reflected in our ProvenCare platform. So the purpose of this study was to assess or measure the reduction of risk of selected microvascular and macrovascular events in a population in which we applied our system of care, that is ProvenCare diabetes. And we compared this to a comparison population of a similar number who weren't under the system of care or ProvenCare. So our intervention population were patients, diabetic patients, who were cared for by our Geisinger clinic physicians, again, under ProvenCare, as compared to a similar population cared for by our affiliated physicians where it was not under that system of care. And so in terms of a little bit of just briefly the methodology of that, this is not a randomized control study, and so we had these two equal populations that we then propensity scored matched in order to minimize the confounding risk factors that might impact the events that we were trying to measure. So this was a 3-year study. It was an all-adult or adult population, a diabetic population that were over 40 years of age, and the statistical method we used in measurement after 3 years, the study was a length of 3 years, was the evaluation or estimation or analysis of what we call a cumulative hazard ratio. It was just a statistical way to measure increase or decrease of risk. And we found, in the end of the day, that there was a highly statistically significant improvement in our intervention group. That is, our group of diabetic patients taken care of by our Geisinger clinic physicians under this system of care. And I just have highlighted some outcomes. So in the end of the 3 years, in the intervention group, we prevented over 300 MIs. We prevented 140 strokes, and we prevented greater than 165 cases of retinopathy as compared to our comparison group. So once again, this was a very important proof of principle for us, both internally and externally. And I encourage you to go to our article to get more detail. So I just want to quickly switch to the prevention side of the coin. This is our performance measure set for adult prevention. Again, when we originally started this and took a look at our baseline, which is our first column, and there was about a little over 200,000 adult members when we did this at that time. Again, a big aha. Just a little bit over 9% of our adult members achieved the full completion of our prevention performance set. So as you can see, several years later, we got above 30% on average of our adult population, and continuing every year we were improving. And then in 2013, and you can see this in red, we made some modifications. So we changed our flu immunization criteria. We added a new metric, the zoster vaccine. And so we had to recalibrate and redo a baseline. And you can see in 2014, with our recalibration, our new baseline, we're around, on average, 20% of our adult population now meets all of those all or none criteria. And so once again, our goal here is every year to see improvement around this, and again, we incentivize our clinical teams to do that. Next. And so my last slide, I just wanted to comment briefly on our provider incentives and alignment. So in Geisinger, our Geisinger primary care physicians can earn up to 20% of their base compensation for non-productivity factors. And the The bulk of those factors or criteria in which they can earn that incentive payment is clearly around quality. And per my second bullet here, we use our all or none performance sets as our way to measure that, and we do it across a number of chronic diseases and adult and pediatric prevention. And so that becomes our major driver in terms of our, if you will, provider incentive program. And lastly, I just wanted to note that we provide our incentive payments on a semi-annual basis as opposed to an annual basis. And we do this to decrease the lag time between performance and reward in order to keep this top of mind with our providers. So that's my last slide. It completes my remarks. Let me hand this over to Alex. Thank you very much.
Thank you, Jeff. So in closing, I wanted to spend a little bit of time talking with you all about first identifying a potential starting point for how to get started on either ProvenCare Acute or ProvenCare Chronic. Also spend some time around the process for implementing such a module within your organization and the support that XG Health and Geisinger are able to provide to organizations. Finally, we'll talk about a few key ingredients for success and give you an example of our growing both ProvenCare Acute and ProvenCare Chronic portfolios. Next slide, please. So when you think about getting started on either a ProvenCare Acute or ProvenCare Chronic module, you know, the first question to ask yourself is really, is there a burning platform for change? And what is the goal of what you're attempting to accomplish? We have organizations coming to us for various reasons, and I'll just outline and highlight a few. We have some organizations that are reaching out to us to use ProvenCare purely as a performance improvement project to improve the quality of care being delivered to their patients. If we think back to the 6 components of ProvenCare that Dr. Casal stepped us through, those would include documenting appropriateness of care, establishing evidence-based best practices, hardwiring them into the electronic health record, and engaging and activating patients in their care. Again, those folks would not be interested in assigning a bundled payment to these typical procedures. However, they would be still using the ProvenCare methodology to improve care for patients. The second group of individuals are folks who are participating in the CMMI, BPCI project. Those organizations are entering into risk-based arrangements with CMS. We believe that in order to be successful in any type of risk-based arrangement, the redesigning of care processes is necessary. So we've taken to those organizations our structured method for implementing ProvenCare and care redesign, as well as been able to share with them our experiences with bundled payments. The final group, an emerging group right now, is are really groups that are preparing for commercial bundled payments and working with health plans in order to take new benefit designs to market. Some of their goals are to, of course, increase their market share and begin to attract business based on high-quality performance within their organizations and hopefully increase the volumes of patients that they're seeing for typical procedures. Once you've determined, what that platform is and what your goal is, it's also important to be sure that there is executive commitment and alignment to resourcing this work. I think one thing that we'll call out, and I want to be sure to be clear with you all about, is it's very important to have IT resources assigned to these projects, so that way the processes can be hardwired into your record and everyone can see the benefits of reliable care redesign. In addition to having the commitment, you'll need to think about what type of condition or module you'd like to focus on. Our experience at Geisinger, beginning with coronary artery bypass grafting, was, again, taking a high-functioning program and improving that from an already strong baseline. We see that as an ideal starting point. However, we have also interacted with organizations that have identified very large opportunities, whether that be from a safety standpoint or a cost standpoint, and they focused on a fixer-upper, if you will, where they could see some immediate gains and improvements. Finally, once you've identified the modular condition that you're going to focus on, you're going to need a clinical leader to carry the flag and lead the team through the ProvenCare process. We call this individual our clinical champion, and we've really had some different individuals in this role throughout our organization. Sometimes this individual has a formal position of power, as a service line lead or a chairman or chairwoman. In other instances, we've had and selected folks who are very passionate about a particular condition and have the respect of their colleagues and peers. I think that is really the most important point to call out. If they are respected by their peers and are known as a content expert, they'll be able to take this multidisciplinary team, lead them through the ProvenCare process, and ultimately see gains in the quality department. Next slide, please. When engaging with XG Health and Geisinger, we have a fairly structured process by which we'll walk you through. Beginning with education on the Geisinger and XG methods for implementation, we'll actually train individuals within your organization through online learning sessions and live interactions on the process itself. At the end of an engagement with us, we would expect that we would have developed the skill set within the individuals that you've selected within your organization, and you would now, as an organization, have the capacity and ability to scale this process and the innovations across your organization. We can also help to accelerate adaptation in your organization. We bring with us, as Dr. Casal again pointed to earlier, we bring our best practices along with our operational definitions as a starting point for your team. This will save some of the labor around doing a deep dive into the literature. You'll be able to, again, accelerate selection of best practices within your organization. However, we do always recommend that you still gain 100% consensus among providers and have the stacking of hands before moving forward. We also have many years of battle scars or scar tissue, if you will, in implementing these processes. So we can provide some insight into barriers that you may encounter or have already encountered and share with you our experiences in overcoming those barriers. When it comes to supporting implementation at your organization, we provide to you our educational tools that we've used to deploy ProvenCare Chronic and Acute across our organization, and we'll work with your teams to develop a structured training plan and rollout strategy. And then finally, we will teach you how to build reports to track your performance. I think this is really a critical component of these ongoing performance improvement projects, is being able to share with the clinical teams in near real time data that shows their individual compliance on both process measures, and then also be able to track outcomes associated with those process measures. Next slide, please. When we talk about critical components for success, I won't read through each bullet point on this slide, but I'll just call out a few key areas. I think the first and most important success factor is alignment of leadership and sending a clear message on what it is the organization and clinical team hope to improve and what the end goal is once this process has been undertaken. Second, having the engaged clinical champion will be key in really driving some excitement around the process, carrying that flag on the day-to-day, and being able to show value to team members and also, at the end of the day, show value to our patients. Third, this notion of IT resourcing. I think that every organization in some way has a story to tell about gaining IT resources. We're no different. As our program has matured, we've actually allocated a full FTE of IT resource to help support our ProvenCare acute programs. That has helped us to kind of fast-track development into the electronic health record, where we have a group working with us side by side throughout this entire process, keeping us honest around requirements for build, and really at the end of the day what we're able to do is turn over a pretty precise blueprint to our IT shop, and they're able to take that and run and build it into the electronic health record. Again, this notion of having believable data to share with providers and being able to share it with them in a timely manner is also critical. Once we walk you through the ProvenCare process, what you're left with is data showing performance on individual process measures, and again, some of those outcome measures. But what we're really looking for is opportunities for continuous and ongoing improvement. In many cases, once we have believable data, this is where the true improvement work begins and goes on until infinity. Finally, engaging patients. This is one area where we at Geisinger continue to evolve. We are activating patients through our patient portal at this time. We've seen that as a fairly reliable method of communicating with patients and reaching out to them to pull them in to receive the care that is necessary for them to receive. Next slide, please. In closing, I just wanted to give you a flash view of the portfolio that we currently have within XG. On the left-hand side, you'll see the ProvenCare acute modules that we have developed and put into a form to share with other organizations and accelerate their movement through the ProvenCare process. In addition, we have 3 chronic and prevention modules that are largely focused on the ambulatory care setting. And as you can see on the right-hand side, we have a number of modules that are currently being packaged to be exported beyond Geisinger. In total, we have now 12 ProvenCare acute modules, and we continue to develop new ones day in and day out. So expect this portfolio to continue to grow. Moving on to the next slide, we're going to pause again and open it up for questions.
Thanks, Alex. Thanks so much. It was a very informative and enjoyable presentation. So just as a reminder to those listening in, you can submit your questions you have into the control panel there. There's a space labeled Enter Question for Staff, and click Send. The presenters will answer as many as they can in the time we have, but then they'll also follow up on those questions they don't have the opportunity to address. So we did have a couple roll in here. One is, when does the patient typically receive the patient report card? Is it during the primary care visit, post-op? Any common times that are best for that?
This is Jeff. From the ambulatory side, it is at the time of the visit, so it's a tool to encourage and facilitate discussion between the physician and the patient.
Okay, great. Another question here is, do you have experience with implementing ProvenCare without bundled payments? And related to that, there was also a question about physician employment, if there needs to be a certain percentage of employed versus non-employed physicians for this model to work.
regarding the question about whether or not, whether there's a percentage of employed or non-employed physician to make this work, we know of systems of both styles, in a sense, those with employed physicians or those that are fully voluntary, sort of staff and faculty. And both have made this work. The difference, frankly, in our experience, comes down to the presence and degree to which a respected clinician, physician champion is present and supported by a strong executive leadership team. Employment, in our experience, despite what you'd think, doesn't give you that much additional leverage when it comes to getting, you know, high-end, especially surgeons, to agree to sort of go along with something they resist. So we would sort of say it's more a measure, or it's more dependent on the team who's leading it, how much support, and how imperative the executive leadership team sort of makes this process, and how early you get the clinicians involved in the process. If they become, you know, if they're at the table from the very beginning, as you make the case for why you're even interested in this, show them the details of current state and sort of the financial realities, the quality issues. We've found examples where it can work either way.
Okay, a few questions were about the evidence-based practices. So one here is, are the steps in each CABG operation performed exactly alike by each surgeon as if following a surgical atlas approach? And there was also a follow-up question to that, is the anesthesia protocol the same for each patient as well?
So this is Casal again. No, not at all. This is the steps of the operation are not rigidly defined. And I think it's important to take a second and use this question to engender a conversation about the complaints that this is about standardization and cookbook medicine and dumbing down physician prerogative and forcing people to do things. It's not in any circumstance that, because the elements that we've chosen and that we encourage other teams to choose to hardwire into definitions of best practice are only those things that rise to the level of being so convincingly documented in the medical literature that they're the right thing to do for this individual patient, that frankly your clinician should be embarrassed to admit that they're not doing it every time. This isn't about forcing or compelling somebody to use a specific size suture or a specific colored drape, or frankly even to do a specific number of grafts. It is about, in our experience, those 120, in our version 2 of the coronary bypass project, we've expanded from 40 to 120 best practices, but it's those 140 things that we believe everybody should have every time. It's not about the things not supported by rock-solid literature. The anesthesia protocols are fairly standardized because there is good evidence to suggest that low-risk patients with certain characteristics can be managed with a fast-track sort of anesthesia program. So our anesthesiologists got together, defined what, quote, low risk meant, what a fast-track protocol in their book was going to be, and then they do implement that on the majority of patients where it's applicable.
Okay, great. And I think that will conclude the Q&A for today. So I want to thank again our presenters, Dr. Davis, Dr. Bulger, Dr. Casal, and Alex Zimmerman from XG for a really excellent presentation, and for all of our attendees who were listening in and participating today. We look forward to having you join us for future webinars. This concludes today's program. We hope you have a wonderful afternoon.